Hello, everyone. Welcome or welcome back to another day or another session of a day with your fertility specialist. I am Joanna Davina and I will be your host for today. Did you miss me? So today we are going to continue talking about labor, right? We're going to talk about the process, and we already started that on Wednesday. If you missed that, please do well to go back and check on that. All our live sessions are recorded post live, so you can always go back and watch it if you were able to join us. So today we're going to be joined again by Dr. Jane. Hi, Dr. Jane. Welcome.
Thank you, Joanna.
Yeah,
How are you?
I'm good. How are you feeling today?
Very well, thank you.
That's amazing. That's amazing. We love for our guests to feel good so we can have their best when they come on here. So we're going to talk about cesarean section, right? The indication for a cesarean section, or is commonly known as CS. So if you're out there and you've heard CS, 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 oh, she gave birth by CS. Oh, I'm going to do CS. I'm going to do CS. I don't want to do labor out CS. Please watch ahead and just stay tuned with us to find out a bit more about this. Like I always say, every session comes with more information. It's a new thing that you might learn. If you're pregnant, if your spouse is pregnant, your partner is pregnant, daughter, your mother, anybody that you know that is considering how their delivery process is going to go, you would do well to share this with them so that they can join us and then they can learn more. And this would also help that to be a bit more of a less nerve wracking process because at least they know what to expect or what their options are. So we're just going to dive in, right? Like I said, we already started talking about labor and then we're going to talk about cesarean section today. So, Dr. Jade, everybody knows CS.
Yes.
Everybody knows CS, whether you go through it or not. Everybody knows CS.
Yes,
But can
sir.
you tell us medically what is a cesarean section? What exactly is a CS? What's is that all about?
Well, cesarean section or in a short form, as everybody calls it, CS,
Mm-hmm.
is a procedure or what we call surgical procedure, or say an operation
Okay.
that involves making a cut
Mm-hmm.
on the skin down through the tissues and also on the uterus.
Okay.
That's the womb,
Mm-hmm.
leading to delivery of the baby
Mm-hmm.
and the products of conception. That's the placenta and the membranes,
Okay.
and with minimal risk to the mother
Mm-hmm.
and the baby.
Mm-hmm.
Yes, basically that is just
That's
cesarean
what it
section,
is. Yeah.
and it's. I would like to add here that is a safe way to deliver.
Mm-hmm.
Yes, no woman that has a cesarean section is short of being a woman.
Sure.
Yes, it's safe for both mother and child, and also when there is a need for a cesarean section, nobody it doesn't make anyone less of a woman, just makes you a smarter woman
Hmm.
and a stronger woman. Yeah.
Yeah, true, true. I mean, thank God you did bring that up because I was going to say you're talking about cutting through layers and layers of a person. I mean, you're saying you're going to cut through the skin and then you go all the way through and then into the uterus. Like that is an organ that is, inside of, the body. So like you said, it's safe, right? It's something that a woman is smart about. If you're making a decision to have a CS, it's something that at least you've gone through and then you've researched and you've spoken to your doctor, your gynecologist about it, your fertility specialist or whatever. So how do you know like to do an emergency CS versus an elective CS? Because that's also something that you hear. Oh, it's an emergency, like maybe the mother or the baby, that kind of thing. You see that a lot in movies. By the
Yeah,
way,
everybody
you
just
say, oh,
running.
yeah, everybody's just running. Like it's the mother or the
Yes.
baby. The husband should choose what's happening like that.
Yeah,
And then
true.
there's now
Yeah.
people that you know of that you hear them say, oh, they are going to the hospital, they are going to have a CS tomorrow. That sounds less of an emergency, like something that you have planned. So what exactly is the difference between those and why would they choose one or the other?
Well, cesarean sections, yes, you classify them as planned
Mm-hmm.
or better, as you said, elective
Okay.
or emergencies. Now, planned cesarean sections are you just have, just like we do emergencies, you
Mm-hmm.
have reasons to go for planned CS. So these women, you would have spoken to them during the course of antenatal. They have met the reason, or they have reasons why they should not attempt vaginal delivery.
Okay.
So you don't have to wait for them to go in labor
Mm.
and now start rushing for an emergency. So these are, and the indications are a lot. So basically, like a woman that's had some of them would have some medical conditions that would not necessitate them from pushing and all of that. Some might just be placental problems. It might be too big baby. So it depends on it. So it could be because of the baby. It could
Mm-hmm.
be because of the mother. Or it could be just the placenta. Well, so those are planned cesarean sections. These are things that we all know the problems they have,
Okay.
and that is why we don't want them to even attempt vaginal birth.
Mm.
Then for the emergency cesarean sections, now these are a group of women who are pregnant, and they have the potentials to attempt to try vaginal birth and also succeed. They have that potential.
Mm-hmm.
But for some reasons, in the course of labor, you now have, or even before they get to labor. So these are a group of women. When you come for antenatal, you also have a birth plan.
Yeah.
So you have already planned that, okay, yes, you don't have any problem at this
Mm. This
time.
is how
We
you
hope
want it
that you
to
get
go.
to 9 months, go into
Mm.
labor and have your baby.
Mm-hmm.
And for some reasons, even before some go into labor, they might now have some problems. The water might break, and what you're seeing is not the baby or anything, rather, you're seeing the cord. You
Okay.
have to take the woman to the theater, even if
Mm.
she has not started the labor or she's not yet in your labor room.
Mm-hmm.
Some others might be in the labor room for one reason or the other, and they start to bleed profusely, maybe from premature separator, or they just bleed, or baby or labor fails to progress.
Mm.
So there are a lot of reasons. So these are women that had potentials to, and they're already in the process.
Okay.
Then for one reason or the other, or baby becomes distressing because of the labor,
Mm.
and now the baby becomes distressed, and the woman is still not close to even giving birth, because sometimes the emergency cesarean sections too, you have to weigh the stage of the labor that the woman is in.
Yeah.
So if the woman is in the first stage of labor where the cervix is not fully dilated, her best option, and you notice any compromise to either mother or baby,
Mm-hmm.
your best option is a cesarean section.
Okay.
But if a woman is now in second stage, baby's head is down, and the skill
Mm-hmm.
or the capacity to conduct what we call instrumental deliveries in a way.
Mm-hmm.
Instrumental delivery, like using some things we call forceps or a cup to
Okay.
pull out the baby.
Oh
If you
wow.
have those, you can attempt that.
Mm-hmm.
But when you don't have the skill for all of those, because the baby to the woman, the for you to do any of those, you must meet some what we call a
Requirement.
criteria.
Okay.
Yeah. So if we don't have any of those, if it's not complete, your best option, and lack of skill, very important, your best option is to also deliver by cesarean section, considering that the skill has been acquired by a lot of persons,
Mm-hmm.
and um, with antibiotics, anesthesiologists, cesarean sections have been made relatively safe.
Okay.
Yes, even though it's not without complications, though, but
Hmm.
relatively safe.
Okay, that's fair enough. That's actually fair enough. I was going to say, I mean, is it that if a woman goes into labor, she cannot have a cesarean section, or she can't have CS because she's already started this procedure? But you've already made that clear. You've already spoken about that. Just because you've already started that labor process, if the potential with for you to have delivered through the vaginal, have a vaginal delivery, could not be met, then it would be advisable for you to. How do you deal with patients that say, "Mm-mm, they will not do
Not in
a
my
CS"?
generation. Well, I think sometimes that comes from a place of not understanding the situation.
Hmm.
I feel if a patient or a parent, better put,
Okay.
has an understanding of the situation. Now, see, madam, your baby is this, that. If with further delay, the baby can go into this stage.
Hmm.
This problem is here. We can't wait anymore. And they have an understanding,
Mm-hmm.
and they have been assured, and they've been spoken to in a way that they understand what it entails to have a cesarean delivery.
Delivery.
I think most times they would accept. Yes, I know the society puts that tag on women who have cesarean sections, and that's why a lot of persons want to decline,
Yeah.
even when they have labored for 7, 8 hours without
Mm-hmm.
any progress and all of that. And you want them to understand. Once they understand the process and what it entails and how
Yes.
the outcomes that you are expecting, we want
Mm-hmm.
a healthy mother. Remember, we said the labor process is not just to come and now deliver and you go home and they say baby is sick or baby
Yeah.
is happy and mother is very sick in the
Mm-hmm.
hospital. We want the outcome of a healthy mother and a healthy baby, and that is what we call normal labor. And unless you are going to achieve all of those, your best option is to deliver through the quickest route with the best skill you have.
Just for the safety of both the mother and the
Baby.
baby. You said something about how even when they've labored for 7 to 8 hours, I mean, how long should a labor even be in the first place? And how long after that, should I say, range of a normal labor, should you start to think, oh, this person is not, I've heard the word progressing, or this person is not moving ahead in this labor?
Well, yes, 7 and 8 hours is just to give you an example, but normally an active so labor has time and what we
Mhm.
call active phase.
Okay.
So most women know that they'll put when they come to the labor room, they tell them you have opened a bit, you are 5 cm and all of
Hmm.
that. That is centimeters rather. That is the mouth of the womb or the cervix opening, softening, shortening, and opening for the baby to come out.
Okay.
So yes, so when a woman gets to, once we say 4 centimeters, we assume that she's in active phase labor.
Hmm.
Now, she at this point, we don't expect her to go beyond 12 hours. Active phase labor beyond 12 hours is prolonged labor. But you don't want to wait for a woman to get to 12 hours. Now, a woman comes to your labor room at 7 centimeters dilated. You expect the woman to make good progress, for her to progress, yes, at least 1 centimeter per hour.
Okay.
So it means that in 3 hours, she should be
Hmm.
full and ready to push her baby.
Yeah.
Then you now come back after 3 hours, she's still 7 centimeters.
Hmm.
You now say, okay, probably she's not contracting well. I need to do this, I need to do this, I need to do that, and all. You still give her another 2 hours. She doesn't make any progress. More like an arrest in labor.
Hmm.
Automatically she's not making progress. And so long as you have met all the criteria at that point, having adequate contractions, baby is not so big, and all of that, and you can't see, and she's not making progress, you do your exams, you check the position of it. Could just be a malposition. It could be baby might not, she might not make progress further if baby is not well positioned,
Positioned.
contractions are not good. If you meet all of those, woman is still not progressing, then she can go. You don't have to wait 12 hours. It means you've spent 5 6 hours.
Yeah.
She's not making progress. So you offer her, so long as that will be the best thing for her at that time,
Mhm.
because you've done 2 consecutive examinations and the woman is not making any
Progress.
progress. Yes,
Oh,
so you can
okay.
offer a cesarean section. So you don't have to wait 12 hours, but first stage labor beyond not you should active phase labor should not go beyond 12 hours. That is called prolonged labor. So
Mm.
you hear women say I was in labor for 2 days, I was in
Yeah.
labor for three
Yeah,
days
you've
and
heard,
all of
I've
that.
heard that.
And you see, sometimes we don't know how effective, that's why we try to define what active phase labor is. So, because a
Mm.
lot of women, when they get to this stage, tend to have this subtle pain that
Yeah.
comes and goes. If you tell them to time it, most times you pick one in maybe every 30, it's not real labor per se, probably just so when you now get to active phase labor where you have consistent contractions that
Mhm.
increasing in, you know, that is when you now start to time properly. So sometimes if a woman now stays that long, 24 hours in that stage, baby is not coming out. Obviously, something is stopping that before. Either it could be the bone, that's the woman's pelvic bone,
Okay.
or it could be the baby size, it could
Mm.
be anything that would stop that baby. So your best option is to deliver through the quickest route, which is a cesarean section.
Mm.
Of course, if she meets the criteria, she'll be
For
counseled
yeah.
appropriately
Yeah.
and consent obtained. I think that would be the best to save her and her
A
baby.
baby.
Remember that prolonged labor too also has a way of affecting the baby, because
Mm.
for every time the woman contracts, um oxygen supply and all the nutrient supply to the baby cuts short.
Oh
That is why
wow.
prolonged labor affects babies a
Oh
lot. So
wow.
by the time they stay there, they keep collecting the heat of the contractions
Mm.
and not coming out
Yeah,
when
and
they are
you're
supposed.
saying the contractions are increasing, so that
Yes,
means the amount of
yes,
time that the baby is short
spending,
of its
yes, very
nutrients
true.
and oxygen is a
It's,
longer period.
yes,
Oh
so
wow.
that now makes them come out. You say baby came out, you didn't cry, and all of that,
Hmm.
because the baby has been stressed significantly.
Oh.
So to avoid such situations, you would rather offer them delivery through the quickest route.
Okay. So I've heard women say this, and like you said, especially in our societies, people put, should I say, some kind of stigma or blame on a woman that has a cesarean section. Why does would do it like the way our mothers used to do it and all
Or
that?
the Hebrew
Yeah, only Hebrew women. We've had that a lot. Is there anything else? Because I know sometimes they'll say, oh, maybe you didn't do enough, or they feel like you didn't do enough. You just rush them to the theater. You just rush them into labor. Like, what are some things that you do prior to um the surgical part of it, or prior to beginning a CS or a cesarean section? Like you said, it might be like the baby is not positioned properly. Can you change the baby's position? Can you, like, what exactly can you do in the labor room, especially if the woman is not in, should I say, immediate distress? What can you do to kind of put her back on track, or if you can put her back on track before looking into the cesarean section?
Well, labor not progressing actually is a lot of factors, or we say
Hmm.
multifactorial. And there are a few things you can do, but not so much. And
Okay.
that is why I said it depends on what you can offer at the time. So a woman's baby is not presenting well. She remains in that stage for 7 centimeters for 6 hours.
Hmm.
Even if you try to change the position, the baby will still not come out because she's fully dilated.
Hmm.
Now the baby has been through a lot and you are struggling and struggling. So your
Yeah.
best option. So for a woman that is fully dilated, head is engaged, the woman is tired, she's exhausted, she's not pushing, maybe what we call, and everything is fine. Head is well positioned, baby is not so big. You could try some of the instrumental delivery using
Like you
cups,
mentioned.
what we
Okay.
call vacuum cups
Mm-hmm.
or forceps. So some of those you can do little or nothing
Mm.
when the woman is not fully there, especially when she's in first stage.
Okay.
Yes, the little thing you can attempt is always in the second stage when the woman is fully dilated, depending on what is presenting, how baby is presenting, that is when you can help. Because even if they are malpositioned, like those that will come with the head, the face facing the woman's thigh. Normally, the babies come with their head facing. So those ones that come that way, with good contractions, they can actually come out.
Hmm.
But if the woman is not contracting well, the pelvis is not, the baby remains there. While some other rotate on their own,
Oh.
just that the labor will take longer time. That is why
Mm-hmm.
sometimes you monitor the patient and give them a little time to see if they can make those rotations and the baby come out. So basically, it's just to monitor your labor, make sure things are going on fine, the baby is well positioned. Anything short of that might be difficult through any other means other than
Mm.
giving them the shortest means of delivery, which is a
Just
cesarean section.
yes. Yeah.
Because a woman that has a contracted pelvis, even if you rotate the baby will still
Mm.
know. Contracted, I mean maybe pelvis that is smaller
So there's no
than it should
room
be,
for the
no room for the baby
baby.
to pass.
Hmm.
Remember, we talked about the baby, the woman's pelvis, and even the
Yeah.
powers. Anything not meeting the standard, what is obtaining, what is acceptable for a normal delivery, you might have to deliver the woman through any of the fastest routes.
Okay. Okay. Yeah. That's. I mean, that's fair enough. Putting both parent and, I mean, mother and baby on the scale, not weighing, just having both of their well-being in mind is what kind of makes your doctor to want to say you should do a cesarean section, because this is the best outcome for you and your baby. But for the baby, how do you know when the baby is not doing so well in the stomach? Like, you something about the baby being stressed or distressed. How do you know that? What are some things that you look out for? What are the signs? How do you check baby? Because baby,
Yeah.
you can't see baby while the baby is still inside. So how do you know what
No.
exactly is going on with this baby that you think, oh, we should go in for a CS?
Well, commonly when baby is stressed and baby is not doing well, what you first pick is their heart rate begins to show some abnormalities.
Okay.
So they begin to go, the heart rate goes very high, all of that. So you know that this baby is this either from whatever reason, probably the baby has stressors in the COVID pregnancy,
Yeah.
and now labor is also because labor is a stressful event.
Mm-hmm.
It's stressful for the baby and the mother.
Mm-hmm.
Yes, I put another stressor like the labor on the
Yeah.
baby. So the heart rate just the first thing you notice the heart rate
Mm-hmm.
of the baby starts to dance.
Okay.
Then sometimes the baby is stressed out. They pass what we call meconium.
Oh, what's
Yes,
that?
so it's just like, well, the fecal matter of the babies in the womb. So when they
Oh,
have that, we call that, and it has to be, it's mostly, you
hmm.
see it's like what we call it, well, very fresh. So you
Okay.
know that baby is stressed out, that's why the baby is passing out that. So you
Hmm.
don't want to wait for it, because when it take longer time, every the contractions are still ongoing.
Okay.
So basically, that is what you pick commonly for a baby. The fetal heart, the heart rate abnormality. Sometimes you could see what we call fresh meconium.
Meconium.
Yes.
Okay. But for the heart of a baby, I mean, just like every other human, we don't always have the same. I would say it's not a plateau that if you check now, you have the same heart rate as you had, let's say, 10 minutes ago
Or
or 5 minutes
before you see a
ago.
dog coming after you.
Exactly. Exactly like that. Oh my god, you just triggered my I am so scared of dogs. If I see a dog right now, my heels will touch the back of my head as I'm running. But yeah, what do you see? Like there like some changes in that heart rate that you would say, okay, let's just see where this goes. How do you differentiate between, should I say, more of a minor change and um a change that would require you to move in for a cesarean section like
Well,
that?
commonly the normal baby's heart rates are counted
Mm-hmm.
with devices,
Mm-hmm.
or with we use the fetoscope, what we call, yes, to put in the ears and count ourselves, and is expected to be within 110 to 160 while the woman is in labor.
Okay.
So anything that goes above 160 is already a problem. So
Hmm.
you want to either change the woman's position, give some oxygen, and do some other things. If the heart rate persists in that pattern, then you know that that high heart rate, the baby is actually compensating at that time. If
Hmm.
nothing is done, then it goes very low. At that time, if your intervention too is super slow, then you might end up not having a live baby by the time you're intervening.
Oh.
So it just goes very high,
Mm-hmm.
struggling to compensate or help
Mm-hmm.
itself. But once you don't respond, so anything above 160, and once you start going below 110,
Mm-hmm.
100, below 100, then you know that you're almost losing that baby.
Okay. Oh, yeah. That's it's a bit grim, but it's I mean it's the truth, something that your healthcare provider would have to look out for. But are there absolute indications, like something that you say once you see this, you have to do this? Yes. I mean, I've heard of you like those excessive bleedings, and I've heard of something like it's called placenta previa. So you mentioned the placenta, something about it, labor being, or the delivery process being the expulsion of the baby and the what do you call it,
A placenta and products
products
of
of
consumption.
conception. Yes. So how does the placenta play a role in your decision to have your patient
Delivered by
yeah,
CES.
do a CS?
Well, so placenta previa, like when, okay, like let me just explain what absolute indication. Of course, an absolute indication means once you see this, it has to be a CS.
Hmm.
Then when this is not there, it might not be a CS. So when you say relative is okay. She could try, but if she doesn't progress, then, so like for instance, a woman has
Hmm.
a baby that's over 4 kilograms, and you would say, most times it's difficult to deliver big babies for obvious reasons. There are a lot of problems that can
Yeah.
happen. But again, someone else can come deliver a big baby and it's fine. Some other
Hmm.
women, some other persons will come in labor with a very big baby, struggle, the head just gets stuck there, no more movement because the pelvis cannot let that
Oh,
size
yeah.
pass. So you see that is a relative. So somebody else is giving birth to 4.2, 4.4. Another person is finding difficult to give birth to a 4 kilogram baby. So
Hmm.
sometimes you see those things, you weigh the options, you look at the woman, her condition, her height, and all those factors, you put them together.
Okay.
So those some of those things are called relative indication. But for placenta previa, well, the placenta previa, they bleed a lot. And placenta previa just means the placenta is staying in an abnormal position.
Hmm.
Normally the placenta should not be down. It
Okay.
should not be before the baby,
Oh, okay.
either the head or the buttock,
Mm-hmm.
whichever is presenting.
Mm-hmm.
Now you now have the placenta coming, and commonly that gives also room for abnormal presentation. So it means that once the woman starts to labor, this, because of it stays in the lower part where there are less muscles, they tend to bleed a lot more. So the woman goes into labor, the placenta is there, struggling to come out, and
Yeah.
the baby has to come out for the placenta. Then it comes out. Sometimes they bleed, the bed bleeds so much. So you don't even want to attempt it. Even when the woman delivers the previa, most often than not, you end up in the theater because the bed might keep bleeding that you have to intervene surgically.
Oh wow.
So you don't want to attempt delivery with a previa because you cannot even predict. And for women that have that, the tendencies for this placenta to also be adhering morbidly, will I say difficult to deliver.
Hmm.
So it's like it's burrowing into the muscles of the
Oh,
uterus.
okay.
So it means that to deliver the placenta might be even difficult. And if you just do a normal vaginal birth, you might now struggle with that, what we call morbid adherence, and that might cause some bleeding. Because for most women, when you have that, you are even thinking about delivering the woman, the baby, and also taking out the uterus, depending on the situation,
Wow.
because those things actually bleed. So you cannot predict all of those. Yes, there are tests or some things you can do to predict this morbid adherence and all of
Mm-hmm.
that. But sometimes most of those diagnoses are made on table while you deliver these women. So you don't
Definitely.
go for any category of previa. They are delivered by cesarean
Hmm.
section.
Okay. Oh well. I mean, I didn't know it was that serious of a thing because sometimes you have a woman bleeding during the course of pregnancy. Let me even ask about that. During the course of pregnancy, if a woman should notice that she's bleeding, is that also a situation for you to advise, or do you have to know exactly what is causing that bleeding and
Yes,
you
you have
know.
to know what's causing the bleeding before you decide on what to do.
Mm-hmm.
Because even at that point, there are some that you have to deliver the baby at the point you are seeing
Wow.
them.
Yeah.
Yes, because if it's a premature separation of the placenta, that's what we call abruption. You
Mm-hmm.
have to deliver that, and the baby is still alive.
Mm-hmm.
It's when the baby is not alive, you can go ahead. What abruption just means is that the placenta is normally sighted, but it's separating before the baby
Mm.
comes out because that is an abnormal situation. So you
Yeah.
are rushing to deliver the baby before the once it's separate, it means the supplies of the baby has been
It's
cut
gone.
short. So
Mm.
you have to deliver and all of that. So there are other causes of bleeding in pregnancy. Yes, commonly we have abruptio, that's premature separation, and placenta previa, abnormally sitting placenta. But aside that, you could have other minor things like on the cervix,
Mm.
have polyps and all those things that could make a woman. Then there are other things when the vessels, if a woman comes in labor and the vessels or the blood vessels, what we call those conduits, those parts take blood to the baby, mother, and all
Okay.
of that. If they are lining around the cervix and the water breaks, they can also bleed from that point. So
Oh, okay.
bleeding can be from anything. And
Yeah.
once you know the reason the woman is bleeding, you would offer appropriate advice. But commonly, the common causes from placenta causes is commonly placenta previa
Hmm.
and abruption, which is premature of the placenta.
Okay. And you spoke about the baby coming out. I mean, after being their nutrients and oxygen being cautious, especially with those difficult and lasting contractions. Other things like other products of conception, which from what you've said so far, I think is just the placenta and the umbilical cord that should be, and the baby.
And the placenta
The placenta,
and the
yeah. And the
membranes.
membrane, right? You
Yes,
said that
that's the
too.
sac that
Okay,
takes
yeah,
the
you
baby up.
said that too. I remember. So, what exactly are there other abnormalities with other products of, let's say, like a cord? Because I've heard of cases where a woman would deliver and you say, "Oh, the cord was around the baby's neck. Oh, the cord was around his feet or something." What other abnormalities can you see in
With
that?
the
Yeah,
cord.
yeah, like with the
Yes, the
cord.
cord can cause a whole lot of problems. Yes, firstly, it can cause this premature separation we're talking about.
Hmm.
Remember that it is laboring and you now have an abnormal cord
Okay.
pulling on the placenta, the
There's
woman can start to bleed and all
there's,
of
there's
that.
a there's a length that the cord is
Yes,
supposed
and
to be.
it's more
Okay,
up to
okay.
100 and standard is 120 centimeters.
That's the size of like
Yes, that's
a
why you
person.
see it. You see it. Yeah, so and then you can also have the cord coming out before the baby,
Hmm.
what we call cord prolapse.
Okay.
So that is also a dire emergency
Hmm.
for any woman in labor, especially when the woman is not fully dilated, because your best route of delivering that baby is through a CS.
Mm.
But even before that, the baby is still at risk because that cord coming out there, if you don't try to do things to take the baby's head or other parts off the cord, it puts a lot of pressure on the cord. Remember that it's not cutting off, can also be from compression and
Yeah.
not just taking off and all of that. So
Mm.
once there's a lot of compression and your intervention time is prolonged, you can also still be. But if the woman is fully dilated, cervix is fully open,
Mm-hmm.
you can actually do um operative vaginal delivery using your cups again or
Okay.
your
All the
yes.
instruments. Okay,
Yes.
okay. That's quite interesting because I mean, like impression of the cord doesn't always have to be that it was cut off or something. Because even you as a person, as a grown up person, you may sleep wrong on your arm, and then you're pressing into your arm, you wake up and it's numb, and you
Very
stop
true.
circulation.
So imagine that for a cord that gives the baby the entire nutrients the baby
Basically.
needs. Yeah.
Mhm.
So it's
So yeah, that's understandable. And then with the things that I'm just going through all the medical jargon I know in my head at you. Things like preeclampsia, rupture. I think you said something about abruptio, but is that the same thing as rupture, like a uterine
no,
rupture?
no,
Like what are these
all these
cases?
ones.
And yeah.
Well, okay, all these two are okay. Uterine rupture. Well, for this group of women, someone is in labor or not even in labor for a few cases,
Mhm.
and the uterus opens. It's like for commonly that's what we fear for is if you want to labor,
Hmm.
the uterus gives way. So what it means is that how would I explain? Nutrients and everything for the baby to cause short. Sometimes the uterus gives way. It's just like the uterus having a CS without you giving a CS.
Oh.
A cut.
Oh.
That rupture is like having a cut or a
Yeah.
tear on your
Mm.
hand. That's appropriate. A tear on the uterus, and it could be any direction.
Mm.
Yes, it could be through a previous scar. That's if a woman has had a CS before.
Okay.
It could be just any direction. And sometimes the baby is now thrown into the woman's tummy.
Mm-hmm.
Yes. You see the baby floating in the woman's tummy, so you just touch and feel the
Oh,
baby. Yeah, it
I
can
mean,
happen.
like outside of
And
the
the placenta
uterus.
even separates sometimes. So you see, so most
Wow.
times they're actually very bad cases.
Mm.
Sometimes you rarely get to meet the baby alive. So what you're going to be battling with is saving the woman's life. These
Oh,
tears can
that's sad.
extend to major conduits or pipes that
Mm.
take blood to the woman's uterus and all of that, and that can lead to significant bleeding. Yeah.
Oh.
So you are trying to save the. So you see, and that is why we discourage the use of all these. A lot of persons abuse some drugs to just
Mm.
take 2 tablets, my superstore,
Hmm.
some will just be all these things to cause contractions in a woman in
Yeah.
labor. We
Yeah.
discourage all of those because sometimes they are not as strong as you think, especially for women that have had multiple babies. As little as any little excessive fire on that uterus, the baby just gives way, and the next thing you're battling with an emergency. This time
Hmm.
is not even a CS. You're actually trying to see if you can repair the uterus
Wow.
and save her life. So basically, that is rupture. Preeclampsia is just basically having high blood pressure
Mm-hmm.
with proteins in your urine.
Okay.
Yes, so if not well managed, the woman can even convulse, what we now call eclampsia.
Hmm.
So depending on the stage she is, the state of her pregnancy, if you're battling to manage the blood pressure, you are seeing her symptoms are worsening. Yes, if a woman is up to 39 weeks, she has mild forms of symptom and all of that, you can
Okay.
actually induce her.
Okay.
But if you see that she still has some journey to make, symptoms are worsening because you're monitoring her blood for some changes and all of
Mm-hmm.
that, you don't want to keep her too long to now have a fit or a convulsion, because that is when sometimes once they convulse, things become very bad and all of that. So you try to deliver if you have issues with blood pressure. So it depends on the state of the woman. So there are a whole lot.
Okay. Okay. But does the health status of the mother kind of is it also an indication for carrying out a cesarean section? When I say health status, I'm talking about um things like HIV, hepatitis or herpes. Does that affect the decision to carry out a cesarean section for the mother?
Well, for cesarean for HIV,
Mm-hmm.
Well, normally you look at what we call the count, the load of the virus in the woman's
Okay.
body.
Okay.
So if it's very high, the risk of transmission, mother to child transmission, is high. So you want to counsel for a cesarean section. But if the count is very low, she can actually go to labor. Same thing with hepatitis B. They are not indications, clear cut, so they are relative, like we just talked about, relative indications for CS. So for those women, you just try to do a lot in labor for them. So there are indications for CS for them mostly for obstetric reasons, like what we
Okay.
have been talking about,
Yeah.
not necessarily for the disease. For
Okay.
if a woman has HIV and she's been on her medication, she can actually go to labor and all. What
Hmm.
you need to do as a healthcare worker is to know things you should do to prevent mother to child transmission of the virus by like taking breaking the water too early, giving a tear too early, because all those things increase your risk and all of that.
Okay.
But once you know the things you need to do in labor to prevent mother child, that's the most important thing, the cause of the labor.
So you're saying that it's very possible for a woman who has HIV or hepatitis or any infectious disease to give birth without transmitting to their child?
And there are a lot of things we do when the baby comes. So
Mm-hmm.
baby could be on some medications, and also for the others, some get some immunizations and all of that. So
Okay.
yes,
And I'm asking
possible.
because I've heard of people, oh, now that they have this or that, that's if they're even comfortable enough to share. They don't think they can get pregnant because, I mean, as far as the child is growing inside them, then this child is going to, carry on this transmissible disease. I've also heard of, cases where it actually happens like this, where a woman who has, HIV or whatever it is, does not transmit to their child. But I know that there are women that can be scared of this because of the notion that once you have a baby, whatever it is, you and the baby are the same. Whether you have
The baby should
your baby would
collect.
also have. So you're saying
No,
that there are some things that we can do
no,
to
there are
prevent that.
a
Okay.
whole lot of women are having babies that are HIV free.
Mm.
To every woman out there, HIV
Mm-hmm.
is not a reason why you should not have babies.
Yeah.
And healthy one at that, at
Mm-hmm.
least healthy babies, you can go the journey so long as you key into the APIN program,
Mm-hmm.
where you get medications, you are consistent on your drugs, baby takes what baby needs to take, and all of that. You are
Yeah.
safe. And
Okay, that's good to know.
yeah.
That's good to know. So you're not discouraged. Like I said, this is something new for especially. I know I've heard of situations like that, but people seem to think it's just a miracle that a woman who has HIV can give birth to a child that doesn't have HIV. But if you do have HIV and you want to get pregnant, you've been trying or you've thought about it, but you're scared about how it's going to go, like Dr. Jean said, it is not a life sentence. You can have your baby, you can have a healthy baby, and you would also be advised to, if you're not already treating or you're not already on medication for it, you'd also be advised to, go on that because you can actually live a very healthy and manage your life very well, even if you have an infectious disease. So, but before we go further into that, or past that, there was something I wanted to ask. I skipped over. You said something about how a uterine rupture is more likely in a woman that has had a previous scar or a CS before. So, how would you advise a woman with that has had a CS before about her next or her present pregnancy on how to deliver?
Well, that is our biggest fear. That is
Yeah.
one of the risks they have when you want to attempt vaginal birth, because of
Hmm.
the strength of contraction can pull on those the scar.
Hmm.
And that is why we encourage women after a cesarean delivery, you should wait a little longer for the integrity or the tensile strength of
Okay.
of the tissues or the muscles there
Hmm.
to get to form,
Mm-hmm.
so that even when you labor, the risk is reduced significantly. Then there are some things, giving of drugs and all of that, to help increase the strength of contraction.
Yeah.
You try to reduce that to the best, to as much as you can for women, except you have something to monitor the strength of contraction. So
Okay.
you know when it's going too high, too low,
Mm-hmm.
because your fear is just not to put so much pressure or tension on the point of the previous cut. Yes, but not just them. Even women that have had multiple babies, it's just like you have a wrapper, you've used it for
Dr. J said a rapper. It's
rapper.
not your uterus she's referring to as a rapper, but
I'm
it's
just
just a
trying to tell
metaphor.
you, yes, how an old rapper would
Yeah.
easily tear to a brand new rapper. So
Yeah.
a uterus that has once twice
Hmm.
has less risk of rupture compared to a uterus who has got that has been pregnant six, five, four times and all of that. So
Hmm.
the more the number, the risk of tear increase.
So you can still advise your talking
Uterus
about that
rapper.
rapper. Still advise your patients to have a vaginal delivery or vaginal birth after cesarean section. It just depends on the healing of C-section and like other modifications you can make,
Yes,
right?
yes, they can. They can. So long as we have a group of things, what we call criteria that they need
Mm,
to meet to attempt vaginal birth, trial of labor
okay.
after CS. So it's something that we do, and a lot of women have also succeeded.
Okay. So about that, like you said, we have some relative versus absolute issues of a cesarean section, right? So how does let me say more of the relative one because the is what might lead to an emergency cesarean section, right?
Yeah.
So is a relative indication. How does that work with your patient's preference? Like I said, woman might you might tell her, oh, this is happening, and then for a cesarean section, but then your patient prefers not to do that. So how can you how does that work? And if you're in that situation, what exactly would you do with your patient?
Well, that's pretty straightforward.
Hmm.
Oftentimes, the women just need the right amount of information
Yeah.
and the conviction from the healthcare provider.
Hmm.
Once you're convinced and you pass the appropriate information, most times they key into what you have to say.
Okay.
Yes, not to take out the fact that we still have some women that say, no, I don't want this,
Yeah.
I don't want that, and don't want that. It's standard thing that for every discussion you have with a client and you think she understands, you are sure she has the capacity to understand that information at the time, then all you need to do is to make sure that you have done your part, documented, and also note that this is what the patient wants and that is why, because it's patient's autonomy we're talking about. She
Yeah.
has right to her body and what she wants to be done for her.
Okay. Okay. So, but is there any sort of how do I say avoidance of certain because we know like medicine is not just absolutely medicine, right? You have other factors. You have especially things like the law involved, right? Is there anything that you would say would let me say like put the healthcare provider away from trying to suggest ACS because I know there might be times where, like I said earlier, a woman will say, "Oh, they didn't do enough in the labor room and they just rushed you into the theater." So are there things that you say, "Oh, yeah, yeah, I probably shouldn't."
Have done this here.
Yeah.
Well, and that is why I said anytime a woman is in the labor room, make sure you
Mm,
give her 100%.
yeah.
If you have to monitor the baby's heartbeat every 15 minutes, please do that.
Mhm.
If you have to make sure the contractions are optimal,
Yeah.
please do that. At the time you are taking your decision, you are convinced that you have offered everything that this patient needs to progress and
Mm,
have her baby. So it's easier for you to tell her this is the problem. You now go because sometimes early in the labor, some of these malpresentations, some of these problems might not be there. So
yeah.
when the baby now gets to a point and is stuck, you want to re-examine, you could feel some things, you're able to convince her you are
Mhm.
contracting adequately, baby's heart rate has been monitored so far up to this point, then baby starts to have a very high, there's a problem.
Mhm.
You don't need to hit too many notes to pass an information. Once you have done what is right, standard practice in the labor room, then once it's time for cesarean section, be firm, take your decision, and let the patient understand clearly why you have to do that.
Okay, so basically, it's just the matter of communicating with your patients.
Communication,
Yeah,
absolutely.
communication. It puts you in a better position. You're more confident doing your carrying out a cesarean section, and your patient is also more confident being in the theater or being into. I know some women are worried about how would I say just even going into the theater, right? It's something that people think, oh, whenever you go in there, there's always one complication or another that must come out of it. So is there something you do to let's you reassure your patients, oh yeah, you can really go into this, like you said, it's a safe procedure. Go in and you can come out and you're fine.
Yes.
Yeah.
So, is there something we do? I didn't get your question.
Yeah, I
It
mean,
was more
like,
like a comment.
yes, okay. I mean, is there some way you reassure your patient a bit more about going in for? I mean, like, if she does agree, or when she does agree to have a cesarean
Okay.
section, just having more of an emotional support.
Yeah, so
Yeah.
well, basically, what you just do is to let them understand the procedure, what it entails, why you are doing it, what
Mm,
could happen, what could go wrong if they don't do the procedure, and what could go not go wrong even if they don't do the procedure.
okay.
Then tell them possible complications. They need to know
Mm,
that this could happen, so they know that yes, we can have safe procedure.
yeah.
Then you now summarize by telling them yes, over time you have done a lot and they have come out great.
Mm-hmm.
Yes, but this can happen, this can go wrong. So all a patient needs is information. So even when things get go bad, they are able to ride along with you
Yeah.
while you manage.
Mm,
And when you discuss those things, you also put measures to
okay.
prevent some of those complications. Once
Sure.
they have that backing and the support, and your words sound very convincing, I
Mm.
think you're good to go.
Oh, okay. Well, thank you so much for that, Dr. Jane. Thank you for telling us more about this, about the cesarean section. It's always lovely having you here. And yeah, just being here, having this chit chat is always really nice. Thank
Yeah,
you. It was nice to have you.
you're welcome.
Yeah. So for our viewers out there, I hope you stayed until the end of it. I know this was a bit of a long one or a bit of a lengthy one, but it's just to put you at rest when you have to make these decisions, and to clear up these misunderstandings and misconceptions that you might have about a cesarean section and how your delivery process will go. Like Dr. Jane said, you have a birth plan. You can always talk to your doctor about what you would like, what you would prefer. Having a cesarean section does not make you less of a woman. It does not make you less of a person in any way at all. It is just you putting yourself and your baby first, okay? Any other person can do whatever they want to do. This is you putting yourself and your baby first. So if you've had struggles thinking about this topic, if you've had comments from societal views or any other place, I hope this has given you more reassurance that um if things are not going according to plan, or even if you want to have this cesarean section electively or you want to plan for it, it is totally fine. It is totally okay. So thank you so much for joining us. As always, we love having you here and we want to see you more and more even in the next ones. Please do well to join us on our social media platforms. We're everywhere. We're on Instagram, we're on TikTok, we're on Facebook, we're on YouTube. You can always go around and watch this. And if you ask someone to join or you shared with someone and they couldn't join, all our live sessions are still uploaded on our pages. So you can go back and watch anything. If you have more questions, please do well to keep those in our comments and we will make sure to reply to those as well as we can in our next session. Join us next week, Wednesday by 3 p.m. for another day with your fertility specialist. Have a lovely day. Bye.